Hey everyone, my name is Daniel Gataulin. I'm one of the senior research analysts covering biotech here at Chardan. It is my pleasure to introduce Steve Pacala, REGENXBIO Chief Medical Officer, to our virtual ophthalmology summit, where today's focus is on wet AMD and diabetes-related ocular diseases. Steve, welcome.
Hi, Danielle. Thanks for the invitation.
Of course. So to start things off, can you please provide a brief overview of REGENXBIO and where maybe highlight some of the most recent milestones?
Sure. So to start off with, our mission at REGENXBIO is to improve lives through the curative potential of gene therapy. And we seek to do this with our proprietary set of AAV vectors from what we call our NAV platform. And these include actually the most clinically validated serotypes in gene therapy. And that's in terms of safety, efficacy, and durability. And this has really allowed us to be leaders in the advancement of the field of gene therapy for over 10 years now. So with that, we've actually been able to advance 3 late-stage clinical programs. And those include RGX-314, which is what we're going to be talking about today predominantly, where we have a global partnership with AbbVie and are advancing 2 separate types of administration, the gold standard approach of subretinal delivery and also an in-office one-time delivery approach of suprachoroidal delivery. And we're looking at wet AMD in a pivotal subretinal program and also wet AMD and diabetic retinopathy with the suprachoroidal program. We won't, I imagine, spend much time on a couple other of our lead programs, but I think it's worth noting that we have RGX-202 for the treatment of Duchenne muscular dystrophy, and we anticipate starting pivotal development in the fourth quarter of this year. And we also have RGX-121 for treatment of lysosomal storage disease, MPS II, that we've already completed phase 3, and we're going to start our rolling BLA submission in the pretty near future. So a lot of impactful programs we're advancing, so I'm happy to have the chance to speak about them. And for this particular forum, certainly our advanced program, RGX-314.
Yeah, excellent, Steve. Thank you for that overview. Yeah, I'm sure we'll find another appropriate time to discuss TOT and 121 in more detail. But yeah, we'll focus on 314 today. Can you introduce us to your 314 programs? You mentioned subretinal delivery. You mentioned the suprachoroidal delivery. Where are you in terms of clinical development for these programs, and what are the next anticipated milestones there?
So just to introduce, so 314 utilizes AAV8 to deliver a transgene for an anti-VEGF monoclonal antibody fragment with the goal of sustained protein production by the patient's own retinal cells. And this gives the opportunity of a one-time treatment that can reduce the injection burden or even prevent the need for future injections for the treatment of wet AMD. But also importantly, can, in the setting of diabetic retinopathy, potentially prevent the need for any future treatment by preventing patients from even developing the vision-threatening complications that diabetic retinopathy patients undergo. So those are the indications that we care the most about because of the unmet need that exists in both those cases. So if we start with subretinal delivery, so we in AbbVie already are well through enrollment in our pivotal program for treatment of wet AMD specifically. And this involves 2 clinical trials, Atmosphere and Ascent, where we're running this program in not just the US, but also Europe and Japan. And that certainly was one of the reasons we were excited to strike our global collaboration with AbbVie so we could really advance this program to have as much of an impact, not just in the US, but globally. And based on these advances, we're on track for our guidance of BLA and other global regulatory submissions in the first half of 2026. And I like to point out this is another example of our leadership in gene therapy, because this is actually the largest gene therapy program ever conducted for any eye indication, but actually for any disease indication in any part of the body. And the other leadership role this program has given is not just in terms of the number of patients, but also in terms of showing durability. So in addition to the advancement of enrollment in our pivotal program, we also have gotten long-term follow-up data from our phase 1/2 study of subretinal delivery for wet AMD. And we have data out through 4 years of follow-up where we see excellent safety and also very durable impact in terms of vision and disease control, with the intended goal of dramatic reduction in injection burden. So we're very excited about the advancement of subretinal. On the suprachoroidal side, I mentioned wet AMD and diabetic retinopathy. Both those programs are in phase 2, where we have ongoing phase 2 trials. And there we've looked at 3 different dose levels in an escalation design, and we've seen excellent safety and also proof of concept in both indications. I think, Danielle, the area that's gotten the most excitement has been the diabetic retinopathy data that we've shown. And this is for a couple of reasons. One is there's such an unmet need in diabetic retinopathy to prevent patients from developing the vision-threatening complications, most notably DME, diabetic macular edema, and also proliferative diabetic retinopathy. And the reason there's this big unmet need is, although repeated injections of existing anti-VEGF injections can stave off these vision-threatening complications, repeated injections for the rest of a patient's life is just not an option that physicians and their patients are going to undergo while they're still asymptomatic. So these patients, even though a couple of the anti-VEGF agents are already labeled for treatment of diabetic retinopathy, they're simply not being used. So these patients are still out there at risk of advancing to blinding eye complications. And what we know is the only viable approach that can address this is a in-office one-time treatment. And that's really the opportunity that we believe RGX-314 suprachoroidal delivery can actually deliver. So you have the unmet need, and now we have the actual data from the phase 2 study where we're seeing good safety, and critically, we're actually already seeing an effect on a pivotal endpoint that's accepted by the FDA, and that's use of the diabetic retinopathy severity score, where we're seeing that we can actually prevent worsening of diabetic retinopathy based on the phase 2 data. And we've actually seen an 89% reduction in vision-threatening complications at dose level 2 compared to our observation control arm. So that's exactly what the retina community wants to see, a one-time treatment that can achieve those meaningful type of effects. So for that reason, we at AbbVie are not only excited about our phase 3 program, but really advancing our suprachoroidal delivery program. And we've already announced earlier this year our plans, along with AbbVie's, to advance diabetic retinopathy toward pivotal development, since we already have reached our target product profile for that indication. And the level of excitement, I think, is shown by the fact that our initial guidance was an end of phase 2 meeting with the FDA in the first quarter of next year. And then as the data has continued to come in and we have been able to advance our planning, we've actually accelerated that guidance to be fourth quarter of this year to have the FDA end of phase 2 meeting. So I think that's a very critical milestone for us that will allow us to actually start a pivotal program for treatment of diabetic retinopathy in the first half of next year. This is important not only for general timelines and advancing an important program, but we also have a significant milestone payment based on start of this trial.
Got it. Okay. Yeah. So thank you for that very thorough overview. As you're thinking about 314 and the market opportunity, which is continuing to evolve, right, with new treatments in development, with TKIs, with anti-VEGFs that are targeting extended dosing intervals. How did your strategy or how did your view on the market opportunity change for 314 in light of all these new products that are being developed? And maybe if you can discuss what patient group or patient groups, both within wet AMD and DR, are likely to benefit most from 314.
Yeah, as you know, Daniil, retina has been a quite dynamic and exciting space over the years, and that continues to be the case when we think of anti-VEGF treatments for the VEGF-driven retinopathies. And we've seen the market grow quite dramatically over the years, and it's globally approaching even $20 billion before too long on an annual basis. And so it doesn't take a lot of math to recognize that if you can fill any unmet need in this large market, that you'll have a blockbuster. And even programs that have incremental improvements have shown how much value is associated with those incremental improvements. And you've mentioned this area of increasing the durability so that you can increase the treatment interval for the patients to have injections into their eye. And that really is the big unmet need, because we know, although the existing anti-VEGFs work in clinical trials over a year, that's because the patients are getting those injections at the prescribed frequency. But we know in the real world, patients are just simply way undertreated. And so patients get worse over time, not better in the real world. So we really do need these advances of increased durability. And we see that the clinicians and the patients value even extension of that interval from 4 to 8 weeks to every 12 weeks to every 16 weeks. These kind of incremental benefits, as you can achieve with high-dose Eylea or the Vabysmo, and perhaps in the future with some of the TKIs, that's very much valued. And so our value proposition hasn't actually changed. It's actually only been emboldened by this confirmation of the importance of decreasing treatment burden. And that's the reason that we think a transformational change, as opposed to an incremental change, that you could potentially have if you have a one-time treatment that gives sustained anti-VEGF coverage, where you can have many patients not only have a decrease in the need for supplemental injections, but even a majority of patients who may not need any injections at all. And that value proposition is not just the decreased injection burden, but it's the translation of that in the real world to better visual outcomes for patients. So certainly for wet AMD, that's the goal, to really stabilize vision and disease, but with a greatly reduced injection burden, which in the real world, we believe will translate into actual better visual outcomes, where patients without such a one-time treatment are not getting enough anti-VEGF coverage. And you asked about which patient segments this really might benefit. We really believe that you can think of the potential benefit across the injection burden spectrum. So just to give an example, I think the more obvious one that people think of is those patients who have a very high injection burden. So let's say the patients who need injections still every 4 weeks or every 8 weeks, even with newer agents. And that makes sense because these are patients who have a very high treatment burden. So if you can reduce that with a one-time treatment, that's certainly a win. If you think of patients who, okay, they're able to have their treatment interval decreased to every 12 weeks or every 16 weeks or even longer, those patients may be very interested as well in the family member who is dealing with taking their mother or father or relative to these frequent visits where injections are given or at least assessed whether injections are needed. In that setting, there's the opportunity, hey, well, maybe I can go from needing injections every 12, 16 or more weeks down to maybe not needing any injections. So we really see the potential opportunity across that board. Now, it may be the penetration may be a little more, a little less in those, but for a retina specialist talking to the patient in their chair, this is really something that we believe has a value proposition that could be explained to patients across that treatment interval range that I discussed. I think the more straightforward case is actually in diabetic retinopathy for the reason I mentioned earlier, that whether it's every 8, 12, 16, even every 6 months, in diabetic retinopathy, before patients have developed the vision-threatening complications, any treatment interval is too much. So in other words, if you have to repeat inject at any interval for the rest of a patient's life, basically, to stave off complications, these patients are not going to sign up for this. And I think many doctors aren't going to even offer it at a stage where a patient is still asymptomatic, even though they're at high risk of advancing to complications. So that's a case where we believe only an in-office one-time treatment can really address that market segment, which is basically patients with diabetic retinopathy at risk for developing either DME or proliferative disease.
Got it. Okay. Yeah, that makes sense. So as you mentioned, 2 of your programs have used or utilized different approaches, right? Your phase 3 trials are subretinal. Your phase 2 program currently is suprachoroidal. Their competitors, intravitreal programs as well. Can you talk about potential advantages of each of those, potential disadvantages maybe? And with your case specifically, can you talk about target populations that would be better suited for subretinal versus suprachoroidal, especially for your competing with AMD programs?
So I think for starters, given our long history within gene therapy, we've always taken a broad perspective that it's not just the gene therapy that you're delivering, it's how you deliver it. And so this is something that right from the get-go was important to us. So our prospective thought process was the initial program should be subretinal, which, while it requires a surgical procedure, it's a very simple surgical procedure. And importantly, it's the gold standard. So the first gene therapy approval for retinal disease utilized subretinal delivery, and multiple programs have shown efficient transduction of the target tissue, the actual retina tissue. So the other benefit is on a safety side, where we know that the subretinal space is relatively immune privileged. So for all these reasons, we felt the lowest risk and the highest probability of success was with subretinal delivery. We also believe, though, that if you could advance and expand over time to have a in-office non-surgical procedure, that would potentially open up a broader patient population where gene therapy could be considered. And to already address the second part of your question in a way, how would that expand the patient population? The target product profile that we've seen for either of subretinal or the in-office approach has actually been pretty similar, in that the value proposition, because of a one-time treatment, is strong enough that even though subretinal requires a simple surgical procedure, that's really a transient consideration when you consider that the goal is to have a long-term benefit. But still, if you don't need a surgical procedure, that's going to tilt the risk-benefit balance at least somewhat, where a little greater proportion of patients would consider getting treated with gene therapy for treatment of wet AMD. Now, it's a much bigger difference, the impact of subretinal versus in-office, when you talk about diabetic retinopathy. So for the same reason that repeat injection with anti-VEGFs is not a viable approach for asymptomatic high-risk DR patients, that's also true for any type of procedure, like a surgical procedure that would be needed. So for all those reasons, we cared about not only advancing subretinal, but also evaluating an in-office approach. And right up front, our view was that suprachoroidal was a better approach than intravitreal. And this relates to the fact that, just like subretinal, suprachoroidal delivery is to a compartmentalized space right next to the target tissue, the retina itself. And this has both potential efficacy benefits, but also critically safety benefits, because this helps keep the gene therapy away from off-target tissue, which is basically all of the rest of the eye and also systemic circulation. And the non-retina off-target tissue exposures has been what's been a major problem for non-localized intravitreal gene therapy administration. So that's why we chose suprachoroidal, and we believe the data to date has supported that selection, because we've seen excellent safety in both our suprachoroidal trials in both wet AMD and diabetic retinopathy, and we've seen the proof of concept that I mentioned previously.
Got it. Okay. And a quick follow-up. Are there certain patients who might not be eligible for suprachoroidal procedure, but will be eligible for subretinal, or vice versa?
So one aspect that we needed to show in our suprachoroidal program was whether pre-existing neutralizing antibodies to the vector AAV8 would matter in terms of safety or efficacy. So with subretinal, we didn't have to worry about that or prove anything there, because we know, because of the relative immune privilege status of the subretinal space, that neutralizing antibody status wouldn't convey any potential impact on efficient transduction and durability and safety and efficacy. With suprachoroidal delivery, we theorized that because it's compartmentalized delivery, that similarly there would be less of an immune response and therefore also less of any potential impact of neutralizing antibody status of patients. We still had to show that. So in both studies in the initial cohorts, we evaluated both neutralizing antibody negative and neutralizing antibody positive patients. And long story short, we saw in both studies there was absolutely no impact of neutralizing antibody status to either safety or efficacy. So that really means that patients independent of neutralizing antibody status can be treated with either subretinal or suprachoroidal delivery. So I think that was the main consideration that people were wondering about with suprachoroidal delivery.
Okay, got it. Makes sense. Let's spend a few minutes and talk about the clinical data for both wet AMD and DR trials to date. I think I'll concentrate on the ongoing phase 2 studies for suprachoroidal space. So first of all, for wet AMD, can you walk us through your AVIATE trial and maybe a quick summary of the results that you've seen to date?
Sure. So AVIATE, we're looking at wet AMD patients treated with suprachoroidal delivery. The design was an ascending cohort design. As I mentioned initially, looking at both cohorts that were neutralizing antibody negative and also positive. And what we've seen in short across the 3 dose levels is that we've had a reduction in injection burden, and we've been able to stabilize vision and also anatomic disease by looking at OCT parameters. And we've also seen excellent safety. We recently announced expansion of the study. We in AbbVie decided that we should also evaluate a dose level 4, and that's 50% higher than dose level 3. And the reason for this is, quite frankly, because we've seen very good safety. And I think one of the other aspects that's supportive of the better safety that we anticipate with compartmentalized administration in suprachoroidal space compared to other approaches such as intravitreal is that later in the study, once we got to dose level 3, we also chose to evaluate short course steroids. And in the AVIATE study, for treatment of wet AMD, we looked at patients treated with topical steroids, a short course of 7 weeks of topical steroids, and also subtenon steroid one-time administration to really explore, okay, we already have very good safety and a low rate of inflammation. Can we get that even lower by applying a very feasible short course steroid regimen? And in fact, that's what we saw. So at dose level 3 with topical administration in AVIATE, we saw 0 cases of intraocular inflammation. And importantly, we looked at short course topical administration in dose level 3 in our Altitude DR study. And there as well, we saw 0 cases of intraocular inflammation. So this all really gave us the flexibility to advance and evaluate a dose level 4. So I think it's fair to say that in wet AMD, because you are looking at multiple endpoints, on the bright side, you have the opportunity to look at the totality of the data, but you also have this background comparison to existing therapies that really warrant full evaluation, looking at longer term follow-up. before making any final decisions on dose selection and design for a pivotal program. Whereas, as I mentioned before, not just for the unmet need in diabetic retinopathy, but also the endpoint is just much clearer in terms of preventing diabetic retinopathy severity worsening and also even preventing vision-threatening complications. That program is just much more straightforward based on the strong data we have there to be able to make the decision to advance to an end of phase 2 meeting with the FDA.
Got it. Okay. Yeah. So as you mentioned, you made a couple of changes or expansions into your wet AMD study. One, as you mentioned, was adding the prophylactic steroid regimen, which lowered the incidence of any inflammation. And another one, more recent, was expanding to a higher dose, dose level 4. Besides the higher dose level 4, which I believe is cohort 7, right? You have 7 cohorts in that study now. Besides the higher dose, are there any other changes in that arm, in that cohort? Is it the same run-in with the anti-VEGF? Any other changes?
Yeah, so we're maintaining the same run-in with 2 doses up front, the screening plus another, and then the top-off dose after RGX 314. And that's to really mirror what we would anticipate doing in a pivotal study. Otherwise, we tried to keep everything very similar so that we can have as much of apples to apples comparison to our prior treatment cohorts.
Okay. And in terms of incremental efficacy improvement, between dose level 3 and dose level 4, what do you think is feasible to expect? For instance, where are you with dose level 3 on key markers of efficacy, and what would justify, sticking with dose level 4 or even potentially, going up a dose if the safety allows?
Yeah, as you can imagine, there's not a black and white answer to that, since it does involve assessing not only the efficacy parameters, but also safety, such as things like if we go up in dose, do we start to see more intraocular inflammation, which we haven't seen at the lower dose? And how does that relate to the different endpoints that we're looking at? And also how long we followed patients. So I'd be afraid to kind of give any kind of solid thresholds, other than to say, of course, if we can decrease injection burden further and or show better anatomic response or better visual acuity response, those would favor going up to the higher dose, whereas any increase in safety findings, and certainly if we were seeing any significant inflammation, that would support sticking with a lower dose.
Got it. Okay. So in terms of the next steps, you mentioned these potential start of the pivotal program, but in terms of the next step, when should we expect the readout, next update on the data for AV8?
Well, we did very recently give an update on dose level 3 in AV8 that supported what we've seen in earlier updates in terms of safety, where we confirmed the lack of intraocular inflammation. I think our cadence that we've shown in the past, I think it's reasonable to think in those terms, that really first we want to make sure we have 6 months of data at least, and longer if we can. But once we start releasing data, often it's a cadence of every 6 months or so for any key data updates. So you can roughly think of it in that term. So we look forward to seeing what we can see with short course prophylactic steroids in terms of safety and efficacy with DL4. We're actually looking at DL4 also in our diabetic retinopathy study. In that study, we actually chose we in AbbVie, to also start exploring diabetic retinopathy patients who already have developed diabetic macular edema, to just further characterize safety and efficacy and ability to impact DME, a related indication. And we know historically that DME and also wet AMD have a higher VEGF drive than exists for diabetic retinopathy. So it's not surprising that perhaps a higher dose might be needed for wet AMD and also DME once it's actually developed. So that's the other important advance, I think, of having started these two cohorts of DL4 for both wet AMD and DME in these two different studies. And I think the ability to do this, we believe, is because of this route of administration where you don't have the significant risks of off-target tissue exposure throughout the eye. And that's normal drug development. If you have good safety, you should explore higher, even in a setting where you've hit a target product profile for one particular indication like diabetic retinopathy. So that's why we're going full steam ahead with our plans of end of phase 2 for diabetic retinopathy, because for that indication, we've already hit the target product profile. But that doesn't preclude continuing to explore the product in other indications.
Got it. Okay. Yeah, I guess I have a similar question to the previous one in terms of the new cohort, the DME cohort in the altitude trial, right, for diabetic retinopathy. Are there any significant differences between how you run the DR cohorts and the new DME?
Yeah, so DME as an indication is significantly different than a diabetic retinopathy indication before patients have developed DME or other vision-threatening complications. So in some sense, it's closer to how we think of wet AMD, where once you develop DME, just like with wet AMD, you definitely need anti-VEGF treatment because you already have symptoms and you already have a clear near-term risk of losing vision and even going blind if you're not getting treated. So unlike in the DR population, here we're looking at previously treated patients. And here also, instead of in diabetic retinopathy, where we have an observation control arm, because patients aren't going to be treated with repeat injection, in DME, we actually have a control arm in our expanded cohort where we're looking at DME, where patients will get a aflibercept repeat injection so that we can actually compare RGX-314 to repeat injection and see if we can decrease the injection burden while effectively treating disease activity of DME. So that's one key difference, and the endpoints are different. So with diabetic retinopathy, we get to look at the diabetic retinopathy severity scale and also prevention of vision-threatening complications. In DME, we look at, since they already have the vision-threatening complication, we look at injection burden that I mentioned, but also disease activity in terms of objectively looking at retinal thickness based on OCT, and also, of course, best-corrected visual acuity. So we have various ways to assess, is RGX-3 working or not, and how is it working compared to existing therapies, repeat injection, anti-VEGF, in this case, aflibercept. And the goal is really to have similar effect in a clinical trial setting on these efficacy endpoints, but with a dramatic reduction in need for supplemental injections, because that's what we know. If you can show that in a clinical trial, similarity or equivalence in a pivotal study, or non-inferiority in a pivotal study, that's actually in the real world going to translate into superiority, because we know in the real world patients aren't getting the aflibercept or other anti-VEGF injections at nearly as frequently as they need to really control these diseases.
Got it. Okay. I see we're coming up on time, but a couple more quick questions. The first one is, I know you have enrolled a fellow eye study, so wanted to ask if you have any updates there and potentially any feedback, from patients who are enrolled in your other studies expressing interest in the fellow eye studies. Yeah, let's start there.
Yeah, so one of the nice things with the AbbVie collaboration that I mentioned is that we've gone global for this program, and we're seeing very good enthusiasm in the US and also outside the US. And that's both at the treating clinician side, where I think it's important to note that in the US, 90% of retina specialists have been surgically trained. And at least in part, they went into this field because they like to do surgery. So there's certainly no bar to doing subretinal delivery. And in this case, it's a very easy and a very short procedure that we've seen no problem upscaling from dozens of retina specialists involved in the phase 1/2 study to now over 200 retina specialists who have been trained to administer RGX-314. And we've seen no issue in terms of their willingness to do it and even their desire to do it, especially given the value proposition. At the patient level, the same is really true. These patients have generally had cataract surgery before, and the treating clinician can accurately say, well, from your perspective, this is really no more involved or longer than what you've already gone through and what your friends have gone through in terms of a cataract extraction. And we have certainly seen that investigators, as they tell us, when they talk to patients about the different treatment options and this experimental treatment option, they are not having a problem enrolling patients. And that's what we're seeing in terms of being able to maintain our guidance for our pivotal program.
Mm-hmm. And with respect to interest in the fellow eye, second eye studies?
Yeah, and we recently announced that we completed enrollment in the fellow eye study. So I think that's a great point. That's another piece of evidence that patients who've been treated in one eye were so happy with the experience that it hasn't been difficult at all to have them sign up to be in the fellow eye treatment study, which is very important from a label perspective. That's why we're doing this study, to see, can you achieve the safety and efficacy in the fellow eye, since most of these patients do have bilateral disease, and the vast majority eventually will develop bilateral disease. And it's also yet another case where better safety and less immune risk is a great differentiator here, because by using compartmentalized delivery like subretinal delivery, there's less risk of systemic exposure. And the reason that's important is if you have systemic exposure, there's more likelihood that you could have primed the patient's immune response such that the fellow eye could have more of an immune response than the initial treated eye. So for us, this is really a great opportunity to demonstrate that in a clinical trial, that based on the compartmentalized delivery approach and less systemic exposure, that we can we intend to confirm that or demonstrate that in this trial, that safety and efficacy in the fellow eye can be comparable to what was seen in initially treated eye.
Got it. Okay. And I guess one last question, maybe in a minute or so. To kind of bring it all together, what do you think investors might still be missing about the REGENXBIO story?
Yeah, I think there's various things outside of the retina program, such as RGX-202 for Duchenne, where we believe that's very differentiated, including with very exciting clinical results, where we're seeing very excellent biomarker results that would be the basis for an accelerated approval. So that's certainly a big area where we think there's value creation. Turning back to the focus of this conference, I'd say diabetic retinopathy is really the biggest value driver, that certainly once we get into end of phase 2 and advance to pivotal, that we see that as a real value driver in terms of increasing probability of success. But frankly, already the fact that we've hit our target product profile on endpoints that are acceptable as pivotal endpoints, we believe this is really an opportunity as we go forward and make some of these regulatory milestones to really achieve the greater value increase that's recognized in our stock. And that's certainly what we're hearing from the retina community. So I think it's just a matter of time before, with these regulatory milestones like end of phase 2 meeting and advancing our phase 3 program, and these are milestones that aren't very far off.
Got it. Okay. Well, we're out of time, but Steve, great to chat with you again, and I look forward to connecting in the future. Thank you again.
Likewise, thanks, Denise.